We do not have community-wide health insurance scheme. The public don't have to pay contributions every month or every year to a health insurance scheme. And we have an ultra low co-payment percentage of less than 3% for the public. And then the government subsidy reaches some 97.6%. From this chart, you can see that the recurrent spending in healthcare, in particular in the public healthcare system, it is now 4.1%. But then with soaring medical costs, public spending will continue to increase on healthcare. So therefore, there's a question that whether the healthcare system is sustainable. It's not just about financial sustainability. It's also about the sustainability of the quality of healthcare. That's why there is need for comprehensive healthcare reform. So with healthcare reform, there is need to consider healthcare services, health insurance, and drugs. So with healthcare, it's about the reform of hospital authority governance and reform of healthcare services. And with health insurance, we have introduced the voluntary health insurance scheme, and we also ensure transparency of fees and charges in the private sector. And then with the government, of course, still pays the most for voluntary health insurance scheme. And so reforming public health care fees and charges is an important element of public health care reform. And that's why we have proposed a comprehensive review and reform for fees and charges for public health care services. Now, the position of the hospital authority is specific. We have to consider the position of the hospital authority, and we have to set priorities for the provision of services. The hospital authority is to protect the underprivileged, is to provide emergency and acute services, and we must also focus our support for the critically and seriously ill. We have to ensure the sustainability of the healthcare system, so we need to ensure there is training, and we need to support research as well. Now, I must stress again, there is a high subsidy rate of healthcare services, that's 97.6%. In our study, we have summarized the four challenges we face. First, there is an imbalance in the structure. Now, in the healthcare systems, there are many seeking treatment for minor illnesses. In the public and private sector, we are seeing mismatch of resources and polarization of public and private services. And there are people with minor illnesses seeking assistance from the public healthcare system, so there's delay, and we are not providing targeted services to our target groups. And then, the cost for some patients are low. In some cases, the services are free, so there's a wastage. Of course, the more serious problem is that demand far outstrips supply. And so there's a long waiting time. In particular, we're very concerned about the possible pressure on the quality of service. The hospital authority has a system to review fees and charges, and we will consider various factors. There are 6 factors. First of all, the affordability of the public. And secondly, whether services could be put to good use, and could there be proper sharing of costs. And most importantly, we need to support the disadvantaged. And then the services must be considered acceptable to the public. Now, there's always been this mechanism to review fees and charges. Review should be done every 2 years. But then the last review was the last adjustment fees was in 2017, 8 years ago. So the review is long overdue, and there is certainly a need to conduct a review. Now, with the reform of fees and charges, we follow 5 principles. First of all, I must stress that this reform is not simply about a review of the fees and charges, but rather as the review is an important aspect of the healthcare reform. First, the government commitment will remain unchanged. It won't be less. All money raised from the reform of fees and charges will be put back into public care services. And secondly, those who can afford should co-pay, and those with minor illnesses should also co-pay the fees. We will adjust the co-payment ratio and the system, but then the co-payment ratio will certainly be affordable to most. And then with this reform, we are increasing certain fees, but also reducing certain fees. Now we are rather increasing protection for poor, emergency, critically ill, and seriously ill patients. And what we're reducing is wastage. And fourthly, we will still maintain a high level of subsidy, 90% as a whole. And finally, we want the public to accept and understand the need for reforms. So we will take a gradual approach. We will reach our target within 5 years. There are 3 reasons for the reform. First of all, by reforming the subsidy model, we can put healthcare resources to better use. We could help the public make better use of our resources. And secondly, we want to reduce abuse and wastage. This will enhance the efficiency of healthcare services. And finally, through this round of reform, we could strengthen healthcare protection for the public. We could also consolidate the community-wide safety net. So if we achieve these 3 goals, then we could enhance the sustainability of the public healthcare system. Now I'll hand over to Dr. Tony Ko, Chief Executive of the Hospital Authority, to explain the challenges the Hospital Authority faces and also the details of the reform package. Thank you.
Thank you. I will now discuss the challenges and our proposal on this reform. In our current healthcare system, we have a number of structural challenges. They are this imbalance in the system. Now, for most patients, primary healthcare expenditure only made up 28%, and for secondary and tertiary healthcare, 72%. So that's for the expenditure. Another imbalance is that between public healthcare and private healthcare. Let's look at doctors. Half in the public and the other half in the private sector. As for the ratio of the recurrent expenditure as a part of the GDP, public 4.1% and 3.8% for the private sector. But for the most heavily used sector, that is inpatient, the 90% of such patients use the public healthcare system. So half of our doctors in the public sector look after 90% of our patients. So that's the imbalance. We also have a mismatch in subsidies. Let's take the accident and emergency department. The A&E department is there to look after critical emergency cases. Every year, roughly 2 million visitors visit the A&E, but nearly 60% of them were non-urgent cases, and that affects our ability to look after critical and emergency cases. So that's an imbalance. The next problem is about subsidy. Minor treatment for minor conditions is heavily subsidized. Let's look at specialized outpatient clinics. For new urgent cases, they make up 25%. As for 75%, meaning most of the cases, those are stable new cases. For major sicknesses, say cancer patients or other major illnesses, they pay large fees for drugs. Roughly 50,000 patients have to fork out for their own drugs. Other patients worry about the fees and they choose not to receive treatment. And the real figure may be larger than that. For the 50,000 patients, roughly 30,000 of them have to pay the full fees. Nearly 2,000 people have to pay $100,000. Some pay close to $1 million for the drugs. The fourth problem, waste. As the secretary said, no fees apply for some treatments, say computer tomography and magnetic resonance imaging. This chart shows over the past few years, more people received CT and MRI, 27% for CT, 12.4% for MRI imaging. And nearly 10% of patients were no-show cases after an appointment. So that's a problem with waste. Another form of waste has to do with drugs. It costs little for you to get drugs at the GOPC because drugs are heavily subsidized. Say for the drugs for asthma, the inhaling drugs, you pay $15 to get 16 weeks worth of drugs. At the private clinic, you pay more than $3,000. Now for paracetamol, a pain relief drug, you pay $15, you get 16 weeks drugs of worth. At a private hospital, you will pay way more than $1,000. So there's an incentive. Waste can happen. Services cannot cope with the demand. We know there's the aging population, more chronic illnesses can be found. In 2011, 13% of the population was aged 65 or above. And then in a few decades, it will rise to 32%, and that's by 2041. More chronic illnesses are another problem. In 2011, it was 27%. By 2041, it will rise to 38%. With the aging population and more chronic illnesses, demand for service has risen. That points to the necessity for reforming the whole subsidy model. The current subsidy model does not reflect where our priority lies. We want to support those emergency urgent cases, and that also fails to reflect the costs and the complexity of the procedures involved. So our reform proposal is trying to change this, where treatment for minor illnesses is heavily subsidized and people are on their own for major illnesses, and people having to fork out for serious illnesses. It's a mismatch of resources. We will also introduce different co-payment levels to guide the public to use the services in an appropriate way, so that there is a reasonable difference between public and private fees. We will also rationalize the services at different places, A&E, inpatient care, and GOPCs, so that people reach out to the family doctors or primary health care first. On reducing waste, we want to make good use of public health care resources. So we will encourage proper use and reduction of waste. We will also maintain a high level of subsidy and a reasonable co-payment amount that's affordable. So currently, pathological tests and non-emergency imaging is fully subsidized, we will make changes to this. We will also make changes so that there is no more hoarding of drugs at home. None of that will affect inpatients or A&E patients. So this slide shows our proposal first for A&E and inpatient cares. For every day of stay, $300. This is slightly higher than the day procedure, which is at $250. Now, those two services are subject to the same charges. So we want to encourage more use of day procedure services. That's to reduce the need for inpatient care. We offer this package deal because that fee covers not just the bed, that also covers the imaging, CT, MRI, drugs. The fee also covers ICU care and major surgeries. On the positioning of A&E, each A&E visit will cost $400. The point is to encourage non-urgent patients to go for other medical options. We want our A&E to look after critical and emergency cases. So with this proposal of a $400 fee, we will waive the fee for level 1 and 2 patients, critical and emergency patients. That's because A&E departments are open throughout the year, round the clock. No appointment is needed. So we want to save those resources for patients with the greatest needs, meaning critical or emergency cases. As for GOPCs and family medicine specialist clinics, family doctors provide the service there. So there will be a flat rate of $150. So these clinics are for patients with complex conditions, where the conditions are fit for treatment, and these outpatients. As for SOPCs, the charge will be $250 per visit. As for the separate fees, for pathology tests and non-emergency imaging and radiology, there will be 3 tiers of fees. And for pathology tests, basic items will be free. And what do I mean by that? The service volume is large, but they're common items. Say you test the blood sugar levels or renal functions. So these items will remain free. For advanced items, we recommend $50. We're talking about more complicated tests, say antibodies in immunological systems. As for the sophisticated services, we're talking about highly complicated, say things involving whole genomic sequencing. That's the sophisticated items, and it will be $200 per visit. Now for non-emergency imaging and radiology, for the basic items most in demand, say X-ray, that will stay free. For advanced items, ultrasonic or imaging, for those will be $250. For the sophisticated services, CT, MRI, invasive treatment, more complex imaging, that's the sophisticated items. So we want to reduce waste by having these tiered charges. And for the services most in need, they will remain free. For drugs, at SOPC, each time it will cost $20, and each time patients will get up to 4 weeks of drugs. For family medicine specialist clinics, for each drug it will be $5 and up to 4 weeks per supply. For other services, say community nurse, community allied healthcare, it would be $100. For geriatric and other rehabilitation services, a flat rate of $100. There's a need for psychiatric services. So for psychiatric day hospital and rehabilitation day hospital, fees will be waived. The public healthcare services will remain heavily subsidized. For beds, for example, the subsidy rate will remain at 95%. For A&E, it will be 80%. Emergency and critical patients will see their fees waived. As for family medicine specialist clinics, 70%, and day treatment, 80%. Fees are waived for the psychiatric services. Fee changes aside, we want to strengthen protection under our public healthcare system. So we will enhance the fee waiver mechanism. 2, there will be a cap on the fee you pay. 3, strengthening protection for patients with severe illnesses, paying for their own medical devices. Now, on enhancing the fee waivers, we're looking at 3 things. 1, relaxing the limits on assets and income. Expanding the scope and duration. And 3, revising the definition of a family. That will mean we will be expanding the number of people who can benefit from 300,000 to 1.4 million.
On enhancing the fee waiver mechanism, there are 3 aspects. 1, to relax the income and asset limits. For the income limit, we will look at the household median income. Now the maximum is 75%, we'll raise it to 100%. As for one-person household, there is a relatively less support, so we propose to raise it from 75% to 150% of the median income. As for asset limit, we will substantially raise it and to bring it on a par with the asset limit for public housing application. And then on the scope, now same as the Samaritan Fund arrangement, for household members not living together, they won't be included in the means test. For example, there are several siblings living together, but their income won't be included for the means test or asset test. And then we will relax the period. Right now, the maximum is 12 months. We'll extend it to 18 months. And then the scope will be expanded to cover those 65 or above may also have their episodic diseases covered. Now, perhaps I can elaborate with examples. For example, there's a 40-year-old cleaner that he doesn't own any property. His monthly income is $15,000. His asset is $280,000. Now he's exceeded the one-person median household income, so he doesn't get any waiver. But after the enhancement, because his income is less than the 150% of the median income, and his assets also less than the asset limit for one person, so he will receive fee waiver. Another common example is, say, there's a 42-year-old patient who needs renal dialysis regularly. Because of his illness, he can't work. He just works part-time as a transport worker, and it's a three-person household. His asset exceeds the limit for a three-person household, so he doesn't enjoy any fee waiver. But after the enhancement of the fee waiver mechanism, because his income is less than the limit for a three-person household, so he receives a full waiver. apart from the waiver I mentioned, in terms of enhancing protection, we'll also introduce an annual fee cap, and it will be $10,000 per year. Well, with such a cap, almost all the 7.5 million residents in Hong Kong may apply for this, and they will benefit from this arrangement. And apart from self-financed drugs and medical devices, all other fee items are covered. Because we see in most cases is those with serious illnesses who will actually incur up to $10,000 of medical fees. So we expect about 70,000 patients will benefit from this arrangement. I can give you an actual example. Now, there are often patients who seek treatment for their cardiac illnesses. Maybe they have complicated conditions. They often have to go to A&E wards, and they may also be hospitalized for prolonged periods. And then the patient has to see different specialists. So with this annual cap arrangement, we can help patients with serious illnesses. Without the cap, that patient may have to pay over $40,000. But now with the cap, the patient needs only pay $10,000, and he won't need to pay any more than that. And on strengthening healthcare protection, we would like to give protection to the critically and seriously ill in terms of drug and medical device. Now, as we've mentioned, we won't reduce our commitment to the healthcare system. We would like to bring in more effective and innovative drugs and medical devices. We want to include some of these items in the standard drug formulary, and then we could also introduce other items into the safety net of the Samaritan Fund. And then there are also special drugs. Hopefully, we could include them in the special drug list sooner. And then we will also relax the eligibility criteria for the safety net. We will relax the calculation of income. We'll also relax the accrual calculation. So with such protection, then middle class families may be able to receive assistance for self-financed drugs and medical devices. And for others who are already receiving subsidy, they may get even more subsidy. Now, these are some examples again. Say a 50-year-old patient. The husband has retired, but unfortunately, the patient has lung cancer, so there is need to pay for self-financed drug, and the cost each year could be some $150,000. The patient has an annual income of $910,000, and also there's disposable asset of $870,000. Under the current scheme, the patient is not eligible for any assistance, but then in the new scheme, the patient will receive a certain percentage of subsidy from the government. Apart from cancer patients, other patients with chronic illnesses may also need drug treatment on a prolonged basis. For example, a 37-year-old patient. The patient has a job and lives alone in public housing. Then the patient has some sort of arthritis, and he needs to be on drugs constantly. The cost may be some $100,000 per year. With his income and asset, currently he's not eligible for assistance, but in the new arrangement, he will be eligible. So in the first year and the subsequent years, you can see that his cost will substantially reduce by 6% to 80%. Now, I would like to sum up. One important objective of the fee reform is that we would like to provide precise and targeted assistance. And then we could strengthen protection for the disadvantaged, emergency, critically ill, and seriously ill patients. And then we could enhance the community-wide safety net. Now, for the those with little means or the middle class. We could give them more assistance. Now, currently, there are 600,000 who are CSSA and old age living allowance recipients. They already receive free treatment, but then with the enhancement, more will benefit from our assistance. And then we could give more support to the disadvantaged, and we could widen our safety net. We would also like to improve the resources available at the accident and emergency ward, because the A&E ward is supposed to handle emergency and critical cases. So we want to reduce the waiting time. More importantly, we want to boost the efficacy of our treatment so there is a higher survival rate. And then we could ensure our safety net is even more robust by improving A&E services. And then there are, we expect about 70,000 patients with serious illnesses. They require prolonged hospitalization or other services. Now we introduce an annual cap of $10,000. So that means that such patients will receive better protection. And so that means we could provide better care and protection to those with serious illnesses. And then even for households with in the middle class, they will receive more assistance if there are family members with serious or chronic illnesses. So that means our safety net will cover more patients. Now, the safety net is supposed to help patients who contract serious illnesses. The safety net is not something that everyone in Hong Kong needs to use all the time. And we don't want the public to have to use the safety net all the time. But at the same time, it's a safety net that everyone needs as a form of protection. So we don't want people to go poor because they have serious illnesses. We hope the public will support the healthcare reform, and then we can build bigger, stronger safety net that will cover more patients. Thank you.
The floor is now open for questions. Please use our microphone. Before putting your questions, please tell us your media outlet and your name. We have many journalists here. Please limit yourself to 2 questions each time. The lady at the back. I'm from RTHK. Now, some questions about the figures. It's about the A&E, the new fee. That's more than doubling the current fee. It's on a par with private clinics' fees. How did you arrive at the fee? And for the $10,000 cap, how did you arrive at the fee? Are you worried that this will lead to a concomitant rise in the fees from private doctors? Now, as for the attendances for A&E, 60% of the patients referred to belong to categories 4 and 5, semi or non-urgent. So under the new model, what will be the reduction in non-urgent cases be like? The last adjustment was 2017, and then the year later, there was a 5% drop in the A&E attendance. So this time around, in next year or in 5 years' time, how much reduction can we see in the A&E attendance? Dr. Tony Ko and Dr. Tang, Simon Tang from the HA will take the questions. On the question about the A&E, 2017, we had the last adjustment. Categories 4 and 5 saw a drop. The situation constantly evolves at A&E. We want to look after critical and emergency cases. Say someone has an acute stroke or myocardial infarction, they have different needs than before. So we have to focus our resources on critical and emergency cases. We want to save them within the 3-hour golden window. Our proposal this time is to encourage patients belonging to categories 4 and 5, meaning non-urgent patients, to other medical options. We will also strengthen primary health care so that we can better look after people who truly need A&E services. On the fees, we propose $400 for A&E. That's close to private clinic levels. A&E is for critical and emergency cases. That's different from people going to a private doctor for a cold or a cough. You spend a few $100s for cough or cold, upper respiratory infection. A&E is different. It's opened around the clock throughout the year. A&E is for the most critical cases, say victims of a car crash or disaster. So you cannot make an apple-to-apple comparison between A&E and private clinics. When you go to a private hospital for A&E, they will be charging you way more than what we propose. Now I want to discuss the thinking behind the fees. The journalist looks at the rise based on the current level. That's not appropriate. We're not adjusting the fee based on the current level. We're reforming the fees. Now, when you look at the rise, for imaging and MRI, it's currently free. So as a matter of math, the rise would be infinite mathematically because you start with a denominator of 0. So we shouldn't get hung up over the current fee level and then arrive at the rise this time. We're looking at a reform, and that's because the current model is unsustainable. It's flawed. There are weaknesses with our current charges and fees, and that prevents us from taking a more targeted approach. So we want people with the means to co-pay, people with minor conditions to co-pay. We look at the cost. And you can see those new fees from the proposed table. A&E should not be compared with regular health clinics on an apple-to-apple basis. We ask people not to treat A&E as the GOPC, because in that case, the critical and emergency cases will be seriously affected. On how we arrived at the annual payment cap, I want to stress this. Strengthening healthcare protection is a key part of our proposal. We proposed 3 points. Each is related to the others. For the needy, people on a low income, we're strengthening the safety net. More people will be able to benefit from the waivers. On the second point, if you don't qualify for the waivers, but you have a major condition, we want this payment cap to give you peace of mind. People may need to visit the hospital frequently because of the condition. That payment cap will be an extra layer of protection. And then for people with critical conditions, they may need costly medical devices or drugs. We want to increase the subsidy for them. So you have to look at the 3 points holistically. The cap is $10,000 per year. Dr. Koh has explained a moment ago that we're relaxing the criteria for the waivers to 100% of the median MMHI. So if you're at the median income, you already qualify for this. For households of one, we're relaxing the criteria to 150% of the median MMHI. So our proposal is trying to target people who are above the median MMHI. And $10,000 is below half the median MMHI. The point is to assure people that they don't get priced out of public health care because of our reform. Next question, the lady in white.
From the South China Morning Post. So first of all, we noticed that there is indeed quite a significant increase in fees at SOPC, GOPC, of course, non-urgent cases in AED and also hospital beds. So does the government have an estimation on how many more patients will be diverted from public to the private market? And also going back to the 10,000 threshold that is applicable to everyone, is it going to create another unfair situation that where the more financially capable people and those who are less capable are enjoying the same level of subsidy? Is the government going to consider a lower threshold for the poor ones? And also, could the government also explain how did you draw the line of $10,000 based on what kind of factors? Thank you.
May I first invite Dr. Goh to answer the first question, and then the Permanent Secretary for the second one?
I think the whole fee structures we will have the advantage of the patients. We want them to, in appropriate settings, use the primary care more often. So there you can see in the fees and charges of, for example, inpatient, outpatient clinics, family medicine clinic, there is a gradation of the fees. So so there's a reason that if the patient is not so complicated situation, they will be more diverted to the primary care settings. The other examples is in the accident emergency department. Past experience showed that after this kind of fee structures reviews, certain percentage of patients, in particular the category 4 and 5 patients, they're more inclined to see alternative methods of care. This is very important because this enables us to have more capability to reserve our manpower resources to take care of the patients who really need emergency, accidents, and urgent care of the patients.
About the enhancing the healthcare protection, I think this time we have proposed 3 measures, and the 3 measures will have to be seen and considered in their totality. I think the first one in improving the waiver mechanism, we have relaxed the income and asset limit significantly to qualify for medical waivers. This is targeting the low-income families. So we expect that low-income families would be mostly be able to be covered by the medical waiver mechanism. Since we have already raised the eligibility level to median monthly domestic household income for families of 2 and more. And for family of 1, actually, we would be relaxing the income limit to 150% of the median monthly household income. And also for the asset limit, we have significantly raised it to match the level for applying for public rental housing. So we expect that the number of low-income families or people that would qualify, potentially qualify to apply for medical waivers would increase from 300,000 to 1.4 million. And this is already in addition to the 600,000 CSSA recipients and also 75 plus OH allowance recipients. So the first measure is specifically targeting the vulnerables and low income. And the second measure of spending cap is to provide an added level of comfort and protection for those patients who may be seriously ill and who may have to receive healthcare in public hospitals multiple times a year or on a prolonged basis. So this is in addition to the medical waiver, we introduce a spending cap, an annual spending cap. That is, if the amount of fees that you need to pay exceed 10,000 for the whole year, anything in excess of 10,000 would be waived. This is to provide another protection for all Hong Kong citizens who may or may not be eligible to apply for medical waivers, but we will assure them that under this public subsidization reform, they would not be required to pay an amount that is unaffordable. And the 10,000 from our estimate is less than half of the median monthly household income. So we try to maintain it to an affordable level. Thank you.
好，下一條。呢邊第三行白色衫位女士。
And next, the lady in the third row. I'm from TVB. The subsidy rate after reform. Now, after adjusting the different fees, in some cases, subsidy may be 70%, and in other cases, 100%. So what are your considerations for such an increase? How come in some cases the subsidy rate is even higher than the 90%? But in some cases, the subsidy rate is lower than 9%. Second question on A&E ward. Now, how much will patients be how many patients will be diverted? Maybe there are non-urgent patients. Maybe even if they pay $400, eventually they could get a waiver. In that case, then the triage effect will not be as pronounced. And then would you change the charging method? So everyone must first pay the $400 first, or do they only pay after they go through triaging? Dr. Tang will take the second question. The secretary will take the first question. About the subsidy rate, I have stressed that the purpose of the fee reform is to bring the subsidy rate to a more reasonable level. This will ensure the sustainability of the public healthcare system. Our aim is to achieve an overall subsidy rate of 90% within 5 years. On the subsidy rate of each fee item, I mentioned the factors that we consider in reviewing the fees. We look at the cost, we look at the priorities of subsidy, we look at whether services are put to good use, and we also look at the affordability of the public. So with every item, the subsidy rate may be different. For example, inpatient fee, we keep it at a relatively high level. Our subsidy rate, that is 95%, because here we talk about patients with serious illnesses, and they may have to be hospitalized for a prolonged period. So the overall subsidy rate is 90% to be achieved over 5 years. But then for each fee item, we have done detailed analysis. We have considered different factors in deciding on the subsidy level rate. Now, for any health insurance schemes around the world, usually the hospital stay subsidy rate is higher, and the subsidy rate is usually lower for outpatient clinics. So we're moving in the same direction. And I must stress, this is reform over 5 years, and we're just taking the first step now. We will keep to the current mechanism of the hospital authority to review fees every 2 years. We will review the effect of the fee adjustment regularly. And the next time when we review the fees and the effectiveness of the reform, We will then adjust the fees accordingly. On triaging in the A&E ward, Dr. Tang will reply to that.
條收費嘅改
The purpose of this reform is to get the public to make good use of medical resources. The same principle applies to A&E. Categories 1 and 2, mean and critical and emergency cases, those need our care the most. We have to offer timely treatment. So for these two types, we will be waiving the $400 fee because these patients need public health care the most. They cannot access the same service in a private setting. Say someone is in a cardiac arrest, no respiration, they need to be resuscitated right away. So in such a case, we waive the fee for that patient. We also want to change people's habit. For categories 4 and 5, they can make greater use of primary health care instead. We want to change people's habit to free up time of our frontline healthcare workers so that they can look after patients from categories 1 to 3. For category 3, our goal is to be able to let them see a doctor. 90% of them see a doctor within 30 minutes. But currently, we're only hitting the target at 77%. With this reform, we hope that there will be fewer patients in categories 4 and 5, and that will mean more resources going into care for patients in categories 1 through 3. And you may wonder if that would mean a shorter wait after the fee increase. We want to devote the resources to patients in categories 2 and 3. The gentleman over there.
RTHK. First, can the government provide an estimate regarding the reduction of non-urgent patients visiting A&E after the new fees are in place? And there have been some comments suggesting that there could be room for abuse as some patients who needed to get perhaps imaging tests done, that they might try to use their own methods to get the tests or scans done at A&E. And what is your take on that? And lastly, any worries regarding the private sector also increasing prices for patients given the changes in public hospital fees? Thank you.
May I invite Dr. Tan to answer this question?
Okay. First of all, regarding the potential abuse of imaging tests in A&E, first of all, we must emphasize that the ordering of such tests will rely on the professional judgment of the doctors. And so it will not be based on the patient's request. Actually, our doctors will based on the patient's clinical condition and then decide the appropriate test and also treatment for the patient. So we are not worried about the abuse of the imaging tests because all these relate to the professional judgment. And also the reform of the A&E charges, the purpose is to divert actually some non-emergent patients not to use the accident emergency services, and there are actually other areas that they can receive treatment, for example, in the general outpatient clinic and also in the private sector. And actually, we have to emphasize that the purpose is to allow our resources to concentrate on managing our category 1, 2, and 3 patients to improve the patient's care. And actually, the purpose of these reform is not to reduce the waiting time of the category 4 and also 5 patients. The purpose is only to improve the service quality and also the waiting time of the most critical and also emergent patients.
下一條，嗰邊第二。
Next question, second row, the lady in black. I'm from Ming Pao. Can the government tell us why $400 for A&E? Is there a target for the reduction in the visits from categories 4 and 5? How much extra revenue will be generated? Some patients groups and frontline healthcare workers worry that the new tiered fee structure will lead to more disputes between patients and frontline workers. What's the government's response? With the new fees, how much revenue would there be, and how much financial commitment will there be for the commitment? Will the revenue be able to cover the new expenditure? If not, are you worried that this reform will not be sustainable? Dr. Tang will take the question about A&E. The Permanent Secretary will take the question on the financial commitment. For the reform involving A&E, categories 1 and 2, critical and emergency, the fees will be waived. There's a large gap between categories 2 and 3. We talk to our frontline workers. For types 2 and 3, those cases are very distinct. When someone visits the A&E, the healthcare workers look at the patient's conditions and vital signs to determine which type the patient falls into. That's down to the professional judgment of the staff. And I appeal for understanding on this point. So we're not worried about disputes over which type patients fall into. Now, on the $400 fee, we should not treat A&E as a general outpatient clinic. So we should not be comparing A&E with a private clinic. For a private hospital offering A&E services, they're charging something different from public healthcare, because at public hospital you pay $400 and you get a package deal. So there's a wide gap between what public hospitals will charge and what private hospitals will charge. On the revenue expected, the reform is not about generating revenue or adjusting fees. We want to reform the fee structure to change the way, the pattern people use public health care. We want to encourage greater use of primary health care. We want to discourage improper use of A&E services. And that covers improper use of non-emergency imaging services. We expect changes in the pattern that people access public health care. At this point, we cannot project the specific change. Based on some rough estimate. And again, there are some assumptions. Assuming certain changes in the usage pattern. We expect the extra revenue to be roughly $3 billion. I want to stress once again, any revenue we get from this fee reform will go into public healthcare services in its entirety. So when you look at the different parts of the proposal, say waivers, annual cap, protection for medical devices, all those costs will be met from the extra revenue. For needy patients, patients with severe critical conditions, we will cover the costs with the revenue. We will take 2 more questions. Second row, the gentleman in white.
I'm from the Economic Times. 97% and 90%, that's the subsidy rate. Now, the current subsidy rate is 97 point something percent, and you say you keep the subsidy rate at 90%. So the difference of 7%. Does it still mean that there is a reduction in government subsidy? Can you explain that further? And then Dr. Koh mentioned some adjustments to fees in 2 phases. So what is the timetable? Yeah, you talk about adjustments in 5 years, or is it the case that maybe 2 years later there will be a new fee table? That's the first question. Second question, delay in treatment. Now, there are various waiver mechanisms. There is the capping mechanism. But then let's use MRI and CT scan as an example. Now, in future, you will charge $500, but then patients may tell you they can't even afford $500 to go and see a doctor. And so with the cap or the waiver, they still have to pay first. And then the government wants to promote primary healthcare. That's the primary purpose. But if people could not even afford $500 and they leave the public healthcare system altogether, how do you address the issue? And what if their illnesses become worse when it's not so bad initially? So have you counted the cost for that? And then the fees of A&E, now Dr. Tang said you want to take care of certain group of patients through A&E service. But then for category 3 patients, the fee will still be increased from $180 to $400. So maybe here we're talking about urgent cases. They need medical treatment urgently, but still they may still be left out of the public healthcare system. So how do you take care of this group of patients? You've asked 3 questions. We'll give a reply to your question on A&E as well. On the subsidy rate, let's look at the principle fee reform. We have proposed 3 principles, if you remember. Now, even if we reduce the subsidy rate from 97.6% to 90%, it doesn't mean the government is reducing the subsidy at all. Our commitment remains unchanged. After we adjust the subsidy rate, all the money raised will still be put back into healthcare services. It's because there is continuous advancement of treatment technology and techniques, and then so we're talking about payment by those who can afford and by those with minor conditions, and then we could offer more protection to the critically and seriously ill. So that's the direction of the reform and the adjustment of fees. 97.6% of subsidy rate, I can tell you, you won't find the same rate in anywhere else in the world. Singapore, our neighbor, they have a health health insurance system, and the people pay for the insurance coverage, but they still have to co-pay their fees, and the subsidy rate is at most 80%. Now, in other places in the world, the whole payment rate is 10%, 20%, or even more. So we're talking about reasonable subsidy rate. We hope that in 5 years, we could achieve 90% of subsidy rate. You mentioned CT scan. We will charge $500 in future. We want to encourage patients to go for primary healthcare services. But CT scan is no longer primary healthcare, is the secondary and tertiary healthcare. You won't get CT scan for minor illnesses. CT scan is mostly for serious illnesses or specialist services. And for these high-end imaging services, CT scan or MRI scan, the cost is really high. So we have to use such resources judiciously. Let's say there is a patient. If he cannot afford $500, there's a high chance that the patient already is covered by the fee waiver scheme. Now, we have done an assessment. If a patient cannot even afford $500 for imaging service, that means there is a high chance that that person is eligible for fee waiver. And for A&E, we're not talking about a two-tier system. Accident and emergency service should be for critical and emergency cases. A&E services are expensive. We're not talking about general outpatient services. If people go to A&E just to get a medical certificate, or they just go there to be treated for flu, well, we don't encourage that. So that's why the co-payment ratio must go up. But then for categories 1 and 2 patients, well, their cases are rather distinct from, say, category 3 patients. And here we're talking about critical condition. Maybe there's already a cardiac arrest, the person is no longer breathing, there is need for emergency resuscitation. So the waiting time is 0 minutes. And so this is a clear case. That's category 1 case. Category 2 cases are people say with low blood pressure, and we must treat them within 15 minutes. So that's why it's easy to distinguish these cases from, say, category 3 cases. And then for categories 1 and 2 patients, we won't charge them at all because we're talking about saving lives. And say there may be unfortunate cases the patients could not be saved. So that's why we want to emphasize that the $400 fee is reasonable. If you look around the world, in many European or American countries, the fee could be some $1,000 US, for instance. And here we have a fee waiver mechanism because we want to emphasize the functions of A&E service. For example, there's a traffic accident. Ambulances take patients to hospitals for free. So we're just extending this concept at the A&E ward. These patients need immediate treatment. Last question, second row, the lady there.
I'm from Tsingtao. Now the $10,000 cap. Within this cap, how much of the cost will the government have to bear in the future? Medical technology keeps advancing. So will the cost exceed the $3 billion of revenue expected? Now, about the phases, phase 1, 2026. So phase 2, can we expect that in 2028? By phase 2, what will the goals be? Will further lowering the subsidy rate be? In Singapore, the subsidy rate is 80%. Is that our final goal? Will primary healthcare services be strengthened, say evening sessions for primary healthcare as a way to encourage greater use of primary healthcare? The permanent secretary will take the question about financial commitment, and then the secretary would take the question about primary healthcare. On the annual payment cap, we looked at past usage data from the HA. With this proposal, we expect 70,000 people who will benefit from the payment cap. The expenditure will be affordable to the government. On primary health care, in December 2022, we launched the Primary Healthcare Blue. The government has been taking forward primary healthcare since then. So we set up district health expresses and district health centers. We have been expanding those facilities. And then we also launched the Chronic Disease Co-Care Pilot Scheme. The government committed vast resources to these schemes. For 2025 to 26, the DHCs and for the CDCC, the government committed more than $5 billion. For this reform, primary health care will be part of the reform, and we will continue to take forward the work. On the subsidy level, our current goal is 90% in 5 years' time, and that's a reasonable level. We also stress that this is about co-payment from those with the means and those with minor conditions. This reform will help us take a more targeted approach in our subsidy. We will be better able to support patients, needy patients, those with critical, severe, or acute conditions. The goal is 90% subsidy in 5 years' time. And we will keep the biannual review mechanism of the HA and make changes when appropriate. There will also be regular review covering the $10,000 annual cap. The Permanent Secretary has discussed primary health care. There are many aspects to reforming the healthcare system, and that covers the services, healthcare insurance, and also drugs and devices. Primary healthcare is a key area. The reform will also help us address the imbalance in the structure and also the aging population. The journalist brought up evening clinic sessions. We're already proposing launching services along that front, and we will continue with the work. That concludes the press briefing. Thank you.